So, we will continue with our last class on diabetes mellitus, and today we are going to discuss complications. As it is a very long deliberation, I will have to push through in between. So, let us start with complications of diabetes. Now, complications are divided into two broad categories, all of you must be aware: acute complications and chronic complications. And diabetes is notorious for its complications only, and that is the reason why we are so much concerned, because chronic complications are life threatening, they are debilitating, and they cause substantial mortality as well as morbidity. Now, let us have a short understanding of acute complications. Important ones are hypoglycemia, which is a very common complication once the patient is on treatment, whether it is oral hypoglycemic or insulin. Take it for granted that sometime or the other a diabetic patient on treatment is going to encounter this complication, and this complication is confounded by the fact that because of neuropathy, and neuropathy too, there is something like autonomic neuropathy, the signs and symptoms of hypoglycemia, they slowly get masked, and more advanced is the diabetes and neuropathy, lesser are the chances that person will have manifestations of hypoglycemia. So, he can end up in major hypoglycemic state, means blood sugar less than 50 or even 40, and may directly become unconscious rather than having early warning symptoms of hypoglycemia, which I will tell you right now. Then there is something like diabetic ketoacidosis, and lastly a relatively uncommon complication more for postgraduate, and that is hyperglycemic hyperosmolar coma or hyperglycemic hyperosmolar state. So, we will go one by one. Hypoglycemia, this is a good pictorial representation of what signs and symptoms are going to develop with a low blood sugar. Symptoms include sweating, feeling tired and weakness. So, these are very vague symptoms. Subsequently, there may be shaking, altered sensorium and unconsciousness. There may be even headache, patient may start trembling, he may start shaking, and there may be intense hunger. And if these are not taken care of, and as I was referring to you, a good number of these symptoms, they are dependent on a normal autonomic nervous system. If autonomic nervous system is not functioning normally because of neuropathy, then many of these symptoms, just like sweating, tiredness, fatigability, tremors, they will not come, and person will keep on getting lower and lower blood glucose levels, and then he can end up directly into semi-comatose stage, or even sometimes he will be wheeled in with a comatose stage. Now, what is the treatment? Treatment, this is the simplest condition to treat as far as the treatment part is concerned, and most rewarding situation. Why I am saying these statements? Because a patient comes on a wheelchair or sometimes on a trolley with all attendants panicking because he has become unconscious. All of a sudden he is a known diabetic and he has become unconscious, and so everybody is concerned. And once you diagnose that yes, he has taken excessive dose of insulin, or he has taken insulin without food, he was having vomiting, diarrhea, some other symptoms, fever, he has taken his scheduled oral hypoglycemic without taking food, then you are having a background of hypoglycemia. And once you measure blood sugar, which is a 30-second job nowadays, just a prick and a test, and you find blood sugar is low, immediately you give dextrose injectable 50%, and patient will start talking, walking and even running. So, this is one of the most gratifying kind of situation where treatment and success is instantaneous, but you have to diagnose it. Even in the household state, when there is no injectable available, you can give half a glass of juice or a little 5 to 6 jelly beans. Diabetic patients, they are always told to keep something of this kind in their pocket, some toffee, some jelly beans, so immediate release of glucose or sugar may be there. Teaspoonful of honey or sugar in household could be a very good alternative, and glucose that contains 15 grams of carbohydrate. So, the most ideal oral is direct giving glucose, but many times you may not be having glucose powder in your household, and so sucrose can be given, but for one situation where hypoglycemia, if it is induced by voglibose and acarbose, then probably sucrose will not be effective, and here you have to use directly glucose. it should be followed by some food, maybe a sandwich, maybe a biscuit, a glass of milk or a piece of fruit, and then patient will be all right, and then you have to relook to his scheduling of drugs, whether he is taking more drug and what was the reason for hypoglycemia, that is to be looked for. Second important complication is diabetic ketoacidosis. Now, this is little more difficult to diagnose, little more difficult to treat. Every day you will find in the ward, in the indoor, 1 or 2 patients are there with diabetic ketoacidosis. It is more commonly seen in type 1, but may be seen in type 2 also. It is because of increased lipid metabolism in face of insulin depletion, which leads to accumulation of ketone bodies, which causes metabolic acidosis and ketosis. So, there is a stage of acidosis along with ketosis, and that is why the name diabetic ketoacidosis. So, it is a summation of ketosis plus acidosis. So, the blood is having acidic content and it is acidotic, as well as there are ketones present in the blood as well as in the urine. Subsequently, ketones are going to come in the urine as well, and that is why diabetic ketoacidosis. Then lastly, there is a condition known as hyperglycemic hyperosmolar state or HSS. Now, this is relatively uncommon condition seen in type 2 diabetes, and if it develops, it is having a substantial mortality and substantial complications, little difficult to treat. So, hyperglycemia, polyuria leading to hyperosmolar state, which causes cerebral edema and can lead to even coma. So, generally patient comes with comatose stage, and this coma takes long time to resolve. Now, coming to manifestations of diabetic ketoacidosis, as I told you, out of these two, you should be more conversant with the diabetic ketoacidosis, because in day to day practice you are going to encounter patients of diabetic ketoacidosis. Hyperosmolar coma is a relatively uncommon condition, and generally it is diagnosed little late, as I told, I will tell you in the coming slides also. Now, the symptoms of diabetic ketoacidosis are nausea, vomiting, increased thirst, polyuria, patient is passing more volume of urine, and abdominal pain. Now, this abdominal pain is a very, very tricky kind of symptom, because there are records where the patient has undergone exploratory laparotomy and subsequently they have been found to have metabolic cause for their abdominal pain, one being diabetic ketoacidosis and other being porphyria, right. So, one should not be under the impression, because they may present just like acute abdomen. Abdominal pain may be very intense, and if it is not being it is for the first time that patient is presenting with diabetic ketoacidosis, it is not known that he is diabetic, then it could be taken as an acute abdomen, and if the treating physician and surgeon, especially because he lands up in the surgical hands and they are not having that much of orientation of metabolic causes causing acute abdominal pain, and suppose surgeon is not aware about it, he may just do the routine checkup and he will be most happy to open the abdomen, thinking that it is acute appendicitis, acute cholecystitis, acute many other conditions are there, acute impending perforation and so on. And so, there are on records not only one but multiple cases where in metabolic state leading to porphyria, either porphyria being responsible or even metabolic acidosis being responsible, where laparotomies have been performed. Now, this gives a message that you should be always in a position to exclude metabolic causes before thinking in terms of acute abdomen and going for surgical procedure. The precipitating event usually is, if patient is on insulin, then adequate insulin intake. Some infections just like pneumonia, UTI, gastroenteritis, any other sepsis is usually precipitating event for diabetic ketoacidosis. Sometimes infarctions just like cerebral infarction means stroke, coronary events just like ACS or myocardial infarction, mesenteric ischemia, peripheral ischemia means DVT, deep vein thrombosis, or sometimes even early gangrenous situations in the lower limb, they may all precipitate ketoacidosis. Sometimes nowadays in the western countries, cocaine is a drug which is very, very commonly used by many youngsters, and so this cocaine may again produce diabetic ketoacidosis. If he is a type 1 diabetes, he has gone to a party where cocaine has been used, then he may come with acute abdominal pain and maybe other symptoms, unconscious state, and this is one of the important differential diagnosis in certain countries, especially Scandinavian countries, and other European countries where type 1 diabetes is more common than India, and secondly cocaine consumption is very rampant in parties, late night parties. They consume cocaine and that may precipitate diabetic ketoacidosis. Physical findings are tachycardia, patient of course is dehydrated, he is in hypotension, tachypnea, one type of respiration which is known as Kussmaul's respiration, respiratory distress may be there may be abdominal tenderness. Now, this is what many times precipitate surgeon to think on the line of acute abdomen, because there may be some vague tenderness in the abdomen and there may be even pancreatitis or surgical abdomen could be diagnosed. Lethargy, subsequently obtundation and cerebral edema may develop and possibly patient may land into coma lately. Now, as I was referring to you, second condition which comes to your mind in this kind of situation is HHS, that is hyperosmolar coma. Now, what are the differentiations between these two? I will not be going in details, otherwise we will not be able to complete the chronic complication. As far as the symptoms are concerned, DKA I have already told you, nausea, vomiting, abdominal pain, thirst, polyuria, breathlessness and acute onset. Usually patient says कि डॉक्टर साहब कल तक बिल्कुल ठीक थे, कल रात को थोड़ा सा बुखार आया, कुछ और तकलीफ हुई, एक आध उल्टी हुई और उसके बाद सुबह से बेहोश हो गए हैं, रात में बेहोशी जैसी आ गई है, कुछ ठीक से बात नहीं कर रहे हैं. दिस इज द यूजुअल presentation of diabetic ketoacidosis. You have to have a high index of suspicion, immediately blood sugar should be done which will be very high, ketones will be present and you can make an easy diagnosis of diabetic ketoacidosis. On the contrary, in hyperosmolar coma, patient directly may end up in loss of consciousness. There may be, to begin with, mental confusion and subsequently altered sensorium. He may be thought that he is having probably a stroke, but it may not be stroke, it may be just hyperosmolar coma. It is preceded by polyuria and poor oral intake. It is generally a classical situation is in a type 2 elderly who is residing alone or there is no one to take care and he is ill, he is not eating properly, he is having polyuria and he has developed gross fluid deficit and slowly he becomes altered sensorium and then the vicious circle becomes more vigorous, because once patient develops little altered sensorium, he is not able to comprehend that I am hungry, I have to take fluid, I have to eat and then slowly he may become unconscious and maybe somebody will notice that he is lying unconscious and then we will be brought to the hospital and diagnosis will be HSS. Signs as far as the DKA is concerned, tachycardia, tachypnea, Kussmaul's respiration, dehydration, abdominal tenderness, lethargy, coma, this I just now told you. Here also coma, altered sensorium will be feature, dehydration, tachycardia will be there, but hypotension is generally late. Cause is different. In DKA, it is generally reduced exogenous insulin, because as I told you, DKA is more commonly seen in type 1 diabetes and ideally these patients are on insulin if they are on treatment. If they are not on treatment, then of course they may be taking some indigenous treatment, maybe sometimes misdiagnosed, taking oral hypoglycemic which will not be effective. So, that kind of situation may be there in minority of patients, but majority will be on insulin where either insulin is inadequate or it has been preceding infection and requirement has become more, and that is why insulin has fallen short for taking care of blood glucose. Blood sugar generally is more than 250 milligram per deciliter in DKA, but in HSS it may be as high as 600 milligram per deciliter. So, if it is a type 2 diabetic and once the blood sugar is done it is very high, maybe 500 or 600, then the chances are you are dealing with diabetic hyperosmolar coma rather than diabetic ketoacidosis. Ketones, they are strongly positive in DKA, whether it is urinary ketone or even in blood you can do ketones plus beta hydroxy butyric acid which is a precursor of ketone, both will be high, but here they may be normal or sometimes mildly elevated. pH usually is less than 3, here pH may be normal just like 7.4. So, it is a classical acidotic situation and hyperosmolar coma acidosis is not that paramount. Osmolarity may be somewhere between 300 to 320, here it is more 330 to 380. You generally do not go for this test routinely. Sodium is usually normal or low, here it could be normal or even elevated. Potassium is normal or low, here it is normal or even elevated. Hypokalemia is a very strong important feature of diabetic ketoacidosis, and it is an integral part of management also, which I will tell you in the coming slide. Bicarbonates are generally low, which could be normal or slightly reduced, and urinary acetones, they are strongly positive where they are absent or mildly positive here. Now, coming to management of diabetic ketoacidosis, mainstay of management remains giving fluids, that is normal saline and subsequently half strength saline. You know, normal saline means 0.9% saline and half strength saline is 0.45% saline. So, here both are required. Then insulin, of course, the plain insulin or routine insulin is the treatment of choice rather than long acting insulins. Potassium and bicarbonate, they will be required at various stages. Identifying and treating precipitating cause, just like infection, acute MI, venous thrombosis, acute respiratory distress, is an integral part in overall management. So, you have to manage diabetic ketoacidosis and you have to manage the second arm, that is why this ketosis has developed, that is precipitating cause, which may be an infection, which may be an acute ischemic event just like a stroke or MI or ACS or mesenteric ischemia or so on. So, you have to identify that and treat that. Now, this is very nutshell of management of diabetic ketoacidosis, because diabetic ketoacidosis management is a full class on its own, but here because I have to complete, I will be telling you in very brief. First thing is confirm the diagnosis. Usually increase in plasma glucose is there, positive ketones are there, metabolic acidosis is there, this all you will get confirmation on investigations. Usually they require hospitalization, so you have to admit the patient. Intensive care setting is required, it may be necessary for frequent monitoring or if pH is less than 7 or patient is unconscious. So, those who are having conscious state, but still they are in ketosis, they could be managed in the routine ward care, but those who are unconscious or having a tendency to become altered sensorium, pH is less than 7, then these are the situations where intensive care hospitalization should be required in these patients. Immediately serum electrolytes, that is potassium, sodium, magnesium, chloride, phosphate, acid base, that is ABG, is to be done, which includes pH, SCO3, PCO2, beta hydroxybutyrate and renal functions. So, sample is to be drawn for multitude of investigations which are going to be important immediately and in subsequent decision making. Then most important part of treatment is replacement of the fluid, because by the time when the patients come in flurried diabetic ketoacidosis, there may be deficit in the fluid by the quantum of 4 liters to 8 liters. That means 8 लीटर तक requirement fluid का within next 24 to 48 hours उसमें आ सकता है. Because of polyuria and dehydration, they have thrown more in urine and body has become hemoconcentrated. So, they are having fluid deficit of a significant degree. So, immediately replacement of fluid is to be done. Immediate 2 to 3 liters of 0.9% saline over first 1 to 3 hours. You see, it is extremely important that you understand magnitude of fluid replacement. A simple ड्रिप लगा दिया, चल रही है 6 घंटे 8 घंटे में 1 पॉइंट चला गया, is going to kill the patient, because the magnitude of fluid displacement is significant, and so fluid replacement has to be very vigorous, and this is the magnitude of fluid replacement. 2 to 3 liters of saline over first 1 to 3 hours, and once I say 2 to 3 liters, it translates into 4 to 6 bottles of normal saline, and this is within 1 to 3 hours. That means, as soon as the patient is hospitalized, within next 2 hours at least 4 bottles or 2 liters, which we are going midway. The requirement may be as low as 1 liter, as high as 3 liters, it will vary from patient to patient, but by and large within 1 to 2 hours at least 4 bottles of normal saline should be pushed in, and for that purpose you will require maybe 2 sites for giving saline, and at the maximum speed possible, thick bore needle, all these things house surgeon or the one who is doing post graduation in medicine or allied subject, they learn that you have to how to replace fluid fast. There are many situations where fluid replacement, just like acute gastroenteritis, cholera and other hypotensive stage of pre-renal kind, fluid replacement is very intense, and that is why until unless you know how to give such massive quantity of fluid within a short period, you will not be able to do it even knowing well. So you have to use a thick bore needle, जिससे blood transfusion देते हैं, वो वाली needle से आपको fluid देना पड़ेगा. You have to give fluid at the maximum with the regulator, and maybe not one side but at least two sides or multiple sides may be used to give fast infusion. Subsequently, 0.45% saline, that is known as half strength saline, which may be given at 250 to 500 ml per hour, and subsequent to this half strength saline, change to 5% glucose and 0.45 saline at 150 to 250 ml per hour when plasma glucose reaches 250 milligram per deciliter. So you have to continuously monitor at least hourly, sometimes half hourly, blood glucose by glucometer, and then accordingly you are going to wean down the fluid and restart half strength saline, and then followed by 5% dextrose as well. Second important arm of the treatment is giving insulin, and the insulin of choice is short acting insulin, which is given IV in the doses of 0.1 units per kg per hour. This is known as low dose insulin therapy. So if patient is 60 kg, which is an average Indian weight of an adult, then if you want to give 0.1 units per kg per hour, then this will be somewhere around 6 units. So 6 to 8 units of insulin per hour has to be given in the form of infusion. So usually infusion pump is set with a calculation that this much insulin in this much 10 ml of pump, and then how frequently you are going to give. You can calibrate the pump and patient will keep on receiving this much of unit of insulin, and this could be adjusted depending on the blood sugar and other parameter. Assess the patient what precipitated the episode: incompliance, non-compliance of insulin, infection, some trauma, or maybe she is pregnant, infarction or cocaine consumption, workup for primary event. So once the treatment has been started, that means insulin pump has been set in, saline has been, infusion has started, then this is the time you have to find out the cause for why patient has landed into diabetic ketoacidosis, and this will be elicited by history and maybe by certain other investigations. Suppose you have gone for CBC and you find count is 20,000 total count, then patient has got some infection somewhere, maybe he is having UTI, maybe he is having pyelonephritis, maybe, so you have to search for it, and relevant investigations will be required, including sometimes blood cultures for sepsis, urine culture for urinary events, and so on. Measure capillary glucose every 1 to 2 hours, measure electrolytes, especially potassium, bicarbonate, phosphate, anion gap every 4 hours for first 24 hours. So it requires a very meticulous monitoring, and the person who is treating has to be fully conversant with what he is doing and why he is doing. If he is not conversant, then probably the management is going to suffer. Monitor blood pressure, pulse, respiration, mental status, fluid intake and output every 1 to 4 hours, because what can happen many times that you can over infuse the patient. So if you keep on infusing, if you do not know that you subsequently you have to wean down the fluid intake, then you can end up in pulmonary edema. Patient may have flooding of fluid inside the lung, and so again that may be a real issue. Replace potassium, that is 10 milliequivalent per hour when the plasma potassium is less than 5.5 less than 5 to 5.2 milliequivalent per liter. ECG may be normal, urine flow normal, creatinine. Administer 40 to 80 milliequivalent when plasma potassium is less than 3.5. So you have to give potassium depending on plasma potassium, and the initial reading may be fallacious because there is concentration of hemo, there is shifting of potassium, and that is why initially potassium may be little high, 5 or 5.2, and still replacement will be required. If initial serum potassium is more than 5.2 millimole per liter, do not supplement potassium until the potassium is corrected. So if it is more than 5.2, then only potassium replacement is not done. Glucose goal is 150 to 200 milligram per deciliter. Never try to bring glucose to the levels of 100, 120, 130, no. It should be as soon as the glucose levels reaches 200, you have to be careful, otherwise you are going to end up in hypoglycemia and counter regulatory hormones will be released, and again glucose will shoot up, and that is known as Somogyi effect, because in body there is a continuous hormonal homeostasis is trying to be achieved. Glucose achievement in the normal range is done by two counter regulatory hormones. You must be aware about it. One is insulin and second is glucagon. So once the insulin it start acting and hypoglycemia sets in, immediately glucagon is going to release, and so blood sugar is going to shoot up again. So, rather than and in that situation you will be treating wrongly, because you will treat hyperglycemia again, you will give more insulin, while here the insulin has to be reduced or stopped because it is Somogy effect. This is known as Somogy effect. So, one has to be concerned, and that is why I am telling that the treating doctor or the resident has to be fully equipped with his knowledge of diabetic ketoacidosis, what can happen, what is happening, then only he can treat. Administer long acting insulin as soon as the patient is eating. So, again you have to switch back to his original scheduling of insulin, whatever he was taking, whether it was basal bolus regime or mixed start regime, and then you have to restart insulin on the protocol of previous, somewhere near the previous dosing. Now, coming to chronic complication, as I told you that this is a very long topic. Chronic complications, they are microvascular as well as macrovascular. Microvascular, they are eye related, just like retinopathy, which could be non-proliferative or could be proliferative. Even sometimes macular edema and optic disc issues may be there. Neuropathy, which is sensory as well as motor, could be mono and polyneuropathy as well as autonomic neuropathy. Nephropathy, which is going to present in the form of albuminuria and declining renal function, and ultimately chronic renal failure. Diabetes is one of the commonest cause of CLD and the commonest cause among the top causes of renal transplant therapy, renal replacement therapy, right. So, it is a big killer from renal angle. Then macrovascular complication is the biggest concern. Coronary heart disease, diabetic patient, they are very prone for CAD, peripheral arterial diseases as well as cerebrovascular diseases. So, all three important vascular trees, that is the brain, heart as well as peripheral vessels, they are involved. So, peripheral will cause gangrene in the lower limb, it is the single important cause of amputation of the lower limb. CAD, that is coronary artery disease, all of you know that myocardial infarction, diabetic patient, they are prone for myocardial infarction and they are prone for stroke as well. Other complications are gastrointestinal, just like gastroparesis, diarrhea, genitourinary, just like uropathy, sexual dysfunction, issues regarding erection and so on. Then dermatological, infectious, cataract, glaucoma, periodontal and hearing loss. Now, this is the pictorial presentation of the same, what complications can develop in what part of the body. Now, diabetes related chronic complications, some important facts I will like to bring to your notice, that diabetes affects many organ systems. Practically it is said that diabetes can affect each and every cell of the body, starting from head to toe, because if you remember my first class, most recently it has been found that dementia is more common in diabetic patient, and so slowly it is getting, so start from brain to the eye to heart to kidney, practically every part of the body, and of course nervous system where the neuropathy is an important presentation. For many years in the US, diabetes has been the leading cause of new blindness in adults, renal failure and non-traumatic lower extremity amputation. So, you can just understand that this is the condition in a condition in a country which is having most advanced health care system and in the entire globe, that is US, right. Europe follows nearly at the same pace. So, even in these countries where the best of the treatment is available, best of the control is they are trying to achieve, it is remains the number one cause for blindness, it is simple important cause for renal failure and non-traumatic lower extremity amputation. But for road accident where traumatic amputations are there, non-traumatic amputation, this is the single most important cause. More recently, diabetes has also emerged as a leading contributor to coronary heart disease. Diabetes associated complications related to hyperglycemia usually do not appear until the second decade of hyperglycemia. In contrast, diabetes associated CHD risk related in part to insulin resistance may develop before hyperglycemia is established. Now, if you remember my first or second class, where I showed a beautiful pictorial graphic representation of timeline of complications and diabetes and insulin and how the diabetes progresses, you must have seen that macrovascular as well as microvascular complications, they precede diabetes. That means, before diabetes is diagnosed, it may precede by 5 years to 10 years. Macrovascular complication even precede pre-diabetic stage. प्री डायबिटीज़ के पहले भी मैक्रोवास्कुलर कॉम्प्लिकेशन स्टार्ट हो चुके होते हैं. एंड सो दिस बिकम्स एक्सट्रीमली इम्पॉर्टेंट. एंड duration and degree of the hyperglycemia, what are the factors which are related to chronic complication? One of course is the severity of hyperglycemia. Then intensive glycemic control is beneficial in all forms of diabetes and all kind of complication. Blood pressure control is critical, especially in type 2 DM. Not all individuals with diabetes develop diabetes related to complication. Other incompletely defined factors appear to modulate the development of complication. For example, despite long standing DM, some individuals never develop nephropathy or retinopathy, suggesting a genetic susceptibility and predisposition, especially in retinopathy and nephropathy. Now, this is again a very important statement, because although hyperglycemia and control of diabetes remains the key for prevention of complication, but if somebody is genetically predisposed for retinopathy or nephropathy, then whatever you do, whatever good control you keep, he is predisposed to develop nephropathy. On the contrary, there are persons who, if they are genetically not predisposed, then probably with worst of the control of diabetes, taking treatment, not taking treatment, intermittent treatment, सब दवाइयाँ बंद कर दी, फिर आ गए, फिर बंद कर दी, फिर चालू कर ली, फिर आयुर्वेदिक ले लिया, फिर होम्योपैथिक ले लिया. A good number of patients they come in that category, and you find assessed kidney functions, they are okay, neuropathy, no symptoms, and so they are fortunate, God has given them some kind of coverage for not developing complication. On the contrary, as I told you, genetic predisposition, there are patients, over patients, where in spite of best control they will end up in CRF, and ultimately they will go for transplantation of their kidney, right. Same is true about neuropathy, same is true about retinopathy to a certain extent. So, again this is how the complications in microangiopathy develops. Now, coming to the macrovascular complications, CV morbidity and mortality in diabetes, I have told you this slide in the beginning also. Higher risk of CV diseases, 72% higher risk of heart attack. So, nearly 75% in comparison to normal population, 52% higher risk of stroke. So, nearly half or double, 1.5 times than the normal population, and 84% higher risk of heart failure. So, nearly double, you can say broadly, in comparison to normal population, they are double, having 84% more risk of heart failure. So, heart failure, stroke, CAD, ACS, they are all killer diseases which are more common in diabetic patients. Prognosis for individuals with diabetes who have CAD or MI is worse than for non-diabetics. So, even if they take treatment and they are nicely being taken care of, overall long term survival in a similar disease pattern in a diabetic versus non-diabetic, diabetic performs very poorly, right. This is a fact. CSD is more likely to involve multiple vessels in the individual with DM. After controlling for all known cardiovascular risk factors, type 2 DM increases the cardiovascular death twofold in men and fourfold in women. CHF is common in long standing type 2 DM. CV morbidity and mortality in DM appears to relate to synergism of hyperglycemia with other CV risk factors such as dyslipidemia, hypertension, obesity, reduced physical activity and cigarette smoking. I have told you this from the very beginning, that approach has to be multi-pronged. Just by control of hyperglycemia alone, you cannot avoid or reduce morbidity and mortality with the CV vascular diseases or macrovascular complication. So, you have to take care of hypertension, dyslipidemia, smoking, lifestyle modification and obesity and any other factor which you think is responsible in this given individual as a co-factor for his increased incidence of coronary artery disease along with diabetes, because diabetes is a lifelong disease. Best you can do is keep a good control. So, same is true about other diseases. Hypertension is a lifelong disease, obesity, dyslipidemia, you have to take care of all. Additional risk factors prevalent include CKD, that is albuminuria, reduced GFR, abnormal platelet function, increased markers of inflammation and endothelial dysfunction. So, these are the other factors which are equally important in coronary artery disease, they contribute their own role. Tight glucose control had limited benefit on cardiovascular outcome in individuals with established CV diseases, suggesting importance of insulin resistance and dyslipidemia, meaning thereby that once a person is having established CAD, he has come with MI, at that time he has been diagnosed as diabetes also. Now, you are trying to control diabetes to the maximum possible by insulin, by maybe other therapies. and you can't compare that with a normal individual, his prognosis is going to remain poor in spite of best control. That is what is the meaning. So, our aim remains glycemic control, blood pressure control, managing dyslipidemia, antiplatelet drugs, because platelet dysfunction is also there, and cessation of smoking, which is a very important. Now, these are few slides which I will have to go through quickly, otherwise I will not be able to cover up other complications. So, hypertension, blood pressure control, screening and diagnosis, what are the protocols? Goals are systolic blood pressure less than 40, diastolic less than 90. Then hypertension pharmacological therapy for patient with diabetes and hypertension, regime that includes either an ACE inhibitor or angiotensin II receptor blocker is preferred. Now, this is a very important practical point which you should remember, that whenever you are treating hypertension in the setting of diabetes, the preferred drug remains ACE inhibition or enzyme blocker. Only in limited condition you will go for calcium channel blocker or other kind of drugs. Multiple drug therapy, 2 or more agents at the maximal dosage generally required to achieve BP targets. Administer 1 or more antihypertensive medications at bedtime. Dyslipidemia, in most adult patients measure fasting lipid profile at least annually. In adults with low risk lipid values, LDL cholesterol less than 100, but those who are having little higher risk, LDL less than 70 will be the ideal. Cholesterol should be more than 50 and triglycerides should be less than 150. So, these are the target values which one has to try to achieve. Statin therapy remains the key for achieving this, and these are the indication how the statin should be used, age more than 40 and less than 40. I will not be going in details. So, statin means atorvastatin. So, that remains one of the key drug for managing dyslipidemia and diabetes. If targets not reached on maximum tolerated statin therapy, alternative therapy just like LDL cholesterol, you have to use other newer therapies which are available. Triglyceride level more than less than 150 milligram per deciliter, and for this you can use, if LDL if atorva alone is not effective, then fenofibrate, which is the second drug used for this therapy, should be started. As far as antiplatelet therapy is concerned, consider giving antiplatelet in majority of these diabetic patients. Primary prevention strategy in those with type 1 or 2 at increased CV risk include most individuals more than 50 years of age who have at least one additional major risk factor, just like family history of CVD, hypertension. Advise all patients not to smoke. Dyslipidemia and albuminuria should always be taken care of. Now, these are the target values of different parameters: A1C less than 7, blood pressure less than 140/90, LDL less than 100, maybe sometimes less than 70, cholesterol, statin therapy for those with history of MI at the age of 40 or other risk factors. So, cholesterol is important and statin therapy should be started. Platelet, antiplatelet if age more than 50 or risk factors are there, and of course, smoking cessation is most important. Now, coming to other complications, these are the microvascular complications. So, we have dealt with the macrovascular complications which are mainly concerned with the cardiac, stroke as well as peripheral vascular disease. Now, diabetic nephropathy. Diabetic nephropathy is the leading cause of CKD and ESRD, that is end stage renal disease requiring renal replacement therapy. The prognosis of individual with diabetes on dialysis is very poor. So, generally long term management on dialysis in diabetic patient becomes really troublesome. Albuminuria in individuals with DM is associated with an increased risk of CV diseases. Individuals with diabetic nephropathy commonly have diabetic retinopathy as well. So, if he is having nephropathy, then there are pretty good chances that he will develop retinopathy, or he might be having retinopathy as well. Smoking accelerates the decline in the renal function, because only 20 to 40% of patients with diabetes develop diabetic nephropathy. Additional genetic or environmental susceptibility factor remains unidentified. Known risk factors include race and a family history of diabetic nephropathy. I have told you this in couple of slides before, that there is predisposition of genetic nature. We still do not know precisely what gene at what locus causes this predisposition, but it is well known that nephropathy is more severe, more aggressive in select group of diabetic patients, and these are probably having some genetic susceptibility. So, they will develop nephropathy whatever you do. The optimal therapy for diabetic nephropathy is prevention by control of glycemia. Intervention Effective in slowing progression of albuminuria include improved glycemic control, strict blood pressure control, and administration of an ACE inhibitor or ARB. So, these are the three important facets. You have to control very strict hyperglycemia control, strict blood pressure control, and administration of an ACE inhibitor or ARB, and dyslipidemia should always be treated. Improved glycemic control reduces rate at which albuminuria appears and progresses in a type 1 and type 2 DM. Once there is a large amount of albuminuria, it is unclear whether improved glycemic control will slow progression of the renal disease. You must be aware that in diabetes, to begin with, there is microalbuminuria, subsequently macroalbuminuria develops. So, anybody who is having more than 30 milligram ACR, that is 24-hour urinary excretion of albumin, is supposed to having diabetic nephropathy, and this will keep on increasing. This will go to 300, this will go to maybe 3 gram or the nephrotic range albuminuria, depending on the quantum of deceased. During the later phase of the declining renal function, insulin requirement may fall as the kidney is the site of insulin degradation. Again, this is a very important clinical point, that you will be surprised that a patient develops complication in the later phase of diabetes, his insulin requirement may come down, he may present more with hypoglycemia, and the reason is because once the kidney parenchyma becomes affected, he is having CKD, then kidney is the site for metabolism of insulin. So, whatever insulin is being produced inside the body, whatever insulin he is receiving as an exogenous insulin, that will remain in the body, and so they require lesser amount of insulin once the nephropathy sets in. Preventing nephropathy, assess urine albumin excretion annually. In type 1 diabetes, patient with diabetic duration of more than 5 years, this should be done. In all type 2, regular monitoring of ACR and regular monitoring of urine albumin excretion is probably the earliest way to tackle nephropathy. Non-pregnant patient with modestly elevated, that is 30 to 299 milligram per day or higher levels, that is more than 300 milligram per day of urinary albumin excretion, use either ACE inhibitor or ARB. So, why we are preferring use of ACE inhibitor or ARB? Because this is a well established drug to prevent microproteinuria. This is the only drug which can reduce microproteinuria to a substantial degree, and that is why if hypertension is there, and even sometimes even if the hypertension is not there, then even non-hypertensive patient, if albuminuria is there, then ACE inhibition is to be done. Reduction of protein intake may improve measures of renal function. Again, we will not go in great details of these. When ACE inhibitor, ARB or diuretics are used, monitor serum creatinine and potassium levels for the development of increased creatinine or change in the potassium. So, whenever you are using these drugs, because one of the common side effect of ACE inhibition is hyperkalemia. So, you have to be careful. Patient may be having advanced renal disease, then ACE inhibitor becomes relatively contraindicated drug in diabetic situation. It is reasonable to continue monitoring urine albumin excretion to assess both response to therapy and disease progression. When estimated GFR is less than 60, and then patient is to be managed on CKD line. Coming to retinopathy, again I will have to be little fast. DM is the leading cause of blindness between the ages of 20 and 74 in the US as well as in India. Several vision loss is primarily the result of progressive diabetic retinopathy, which leads significantly ultimately macular edema. So, this could be non-proliferative diabetic retinopathy, or this could be even proliferative retinopathy. So, I will not be going in details of this non-proliferative and proliferative, but overall intensive glycemic and BP control will delay the development or slow the progression of retinopathy. So, these are the only two arms which are in your hand to control progression of diabetic retinopathy. One is hyperglycemia, so best control of hyperglycemia. Number 2 is blood pressure, best control of blood pressure, right. But even with these control, it is not necessary that you will be able to prevent the development of retinopathy as well as the progression of retinopathy. Generally, it will be to begin with non-proliferative, later on this will transfer into proliferative retinopathy, which is a more dangerous situation, because ultimately this proliferative retinopathy may form bands and adhesions, and it may contract and pull, and then retinal detachment and blindness will develop. So, this is usually what happens, and of course, there are treatment where to a certain extent this could be treated. Coming to diabetic neuropathy, again this is a very area where nothing much could be done. Because this occurs in 50% of individuals with long standing type 1 and type 2 diabetes, manifests as diffuse neuropathy, distal symmetrical polyneuropathy and or autonomic neuropathy. So, as I have been referring to time and again that a good number of these patients, they develop autonomic neuropathy as well, and that is why they will not manifest hypoglycemia. As with other complication of diabetes, development of neuropathy correlates with duration of diabetes and glycemic control. So, these are two important checkpoint. Additional risk factors are BMI, greater the BMI, greater the risk of neuropathy, presence of smoking, CVD, hypertension, elevated triglyceride, they are also associated. This neuropathy is of both types, sensory as well as motor, and even as I told you, it is autonomic neuropathy as well. Physical examination often reveals sensory loss, loss of ankle, deep tendon reflexes, abnormal position sense and muscular atrophy or foot drop may develop. Mononeuropathies can occur at entrapment site such as carpal tunnel, or maybe non-compressive involvement of the third cranial nerve is most common and is heralded by diplopia. So, this is again a presentation of diabetic neuropathy. All patients should be screened for distal symmetrical polyneuropathy and autonomic neuropathy at diagnosis of type 2 diabetes and 5 years after diagnosis, and for that you may have to require monofilament test and subsequently nerve conduction velocity. Now, these are the various types of diabetic neuropathy. As far as the treatment is concerned, can involve multiple system. CV autonomic neuropathy reflected by decreased heart rate variability, resting tachycardia, orthostatic hypotension, increase in CVD and sudden death. Gastroparesis, bladder emptying abnormalities, these are all because of autonomic neuropathy. Hyperhidrosis of the upper extremities and anhidrosis of the lower extremities may result from sympathetic nervous system dysfunction. So, as I have been referring to you from beginning, autonomic neuropathy is an important integral part of diabetic neuropathy, and this is the one which creates lot of problem in management. Prevention of diabetic neuropathy is critical through improved glycemic control, lifestyle modification, exercise, diet has some efficacy. Hypertension, hypertriglyceridemia should be treated. Autonomic neuropathy may reduce counter-regulatory hormone release, leading to an inability to sense hypoglycemia, thereby subjecting patient to the risk of severe hypoglycemia. This I have been referring to you from the very beginning. Avoidance of alcohol, smoking, supplementation of vitamins, especially B12 and folate, and there are many other drugs which may help, just like pregabalin, tricyclic antidepressants, gabapentin, phenexamine and carbamazepine, tramadol, they are sometimes useful. Now, coming to diabetic foot care, again this is the entire topic on its own. There are books on diabetic foot care, because once foot ulcer develops in diabetes, you see it is a premonition for oncoming amputation, and that is why prevention is better than cure. You all of you know it. So, you have to take care of your foot. So, diabetic patient has to be advised, just like his face, he should be concerned about his foot. Any change, any small ulceration, any small induration, any small area where he thinks is suspected area, he should consult his doctor and accordingly treatment should be started. Because once an diabetic ulcer sets in, because there are multiple inputs for this ulcer, one is neuropathy, there is no sensation, decreased sensation, second is angiopathy, there is decreased circulation, and third is diabetes itself is a immune compromised state. So, there is immune deficiency. So, once there is a nidus for infection, then it becomes very difficult, healing is not possible. So, if you see a diabetic ulcer patient who develops diabetic foot, he keeps on coming and coming and coming, and ultimately either a toe amputation will be required, or subsequently if it keeps on increasing, then the line of demarcation, depending on the line of demarcation is spread, you have to keep on removing. So, to begin with maybe a toe amputation, subsequently below knee amputation, still later on below ankle amputation and below knee amputation. So, sometimes one diabetic patient may have undergone multiple surgical procedures for saving his life, because if you do not remove that dead tissue which is gangrenous now, he is going to spread in the entire body and he is going to die because of gangrene. And so, this is one of the most important situation which is to be taken care of, and for that there are specialized centers, diabetic foot care centers. But important thing is that individual with foot ulcer, high risk feet especially prior ulcer or amputation. They should be smoking should be avoided, protection of footwear, kind of footwear. So, there are multiple things which can be directed toward this, and this is a beautiful representation of a pictorial representation. Someone may come to the attendance, आप एक जना आ जाइए attendance लेने के लिए. So, you are seeing this is a beautiful representation how the diabetic foot care could be done. It starts from wash your feet in warm water every day, dry your feet well, especially with a towel just like your face, keep the skin soft, use some moisturizer so that skin remains supple, inspect your feet every day just like you are seeing your face, ask your diabetes care team if there is anything which you are thinking that this is abnormal, wear clean soft socks, keep your feet warm and dry, never walk barefoot, especially in the rural areas. Person may be diabetic, he is working in the field barefoot and he develops a big ulcer because he is not aware about the injury which he is sustaining because of neuropathy, and then things becomes worse. And examine your shoes every day for cracks, pebbles, nail or anything that could hurt your feet. So, there are many things which could be done to prevent this diabetic foot, and prevention of diabetic foot is the best remedy for long term. Otherwise, if it develops, then really it is troublesome. So, this is all for diabetes as far as the lectures on diabetes are concerned. The coming class will be taken on 24th by Madam Gynae head, because she has changed that from me on 9th. Please.
Roll number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12,